Well, hello, everyone. I am absolutely thrilled to have the opportunity to moderate this wrap-up session. I am using a sign language interpreter for communication access purposes, so just a reminder to all the folks on the panel, please feel free to ask for clarification at any time. I'm a white presenting woman with auburn hair, long hair, and I'm wearing a black shirt with a brown blazer. I have a white background as well. Today is our wrap-up session about connecting what we've learned and our action and the missing links, the missing steps. That will be the format for this session that I'll be moderating. We'll have a wonderful opportunity to get a chance to discuss the various presenters, and what we've learned, some of the common themes, and focus on building tools, a toolkit, and be action-oriented. It is my honor to be a part of this and have the participants respond to one another. We have such an amazing panel. I'd like to introduce Lisa Meeks. She's an associate professor of learning health sciences and family medicine. She's also the executive director of Doctors with Disabilities Initiative, a lead author of the AAMC Special Report, Accessibility, Inclusion, and Action in Medical Education. And also we have collaborated before. Secondly, I'd like to introduce Day King Campbell, who works at Stanford's OBGYN and CME departments for 36 years now. Her current position is with OBGYN Education and DI Projects Coordinator at Stanford. She's also on the SMATI Board of Directors, and she also runs the Disabilities in Medicine Mutual Mentorship Program. For many years working with children in children's education as a doula as well, early child education, and is now very interested in bringing this information and learning to the DEI space. She also has family members who have lived with chronic illness, working for nonprofit services, families of children with disabilities and chronic illnesses as well, and has been a great advocate in this area. And thirdly, I'd like to introduce Cameron Whitley. He is an associate professor of sociology at Western Washington University with a special focus on transgender affirming medicine. Cameron, importantly, has lived experience as a kidney transplant recipient. And that process has certainly helped him, is something that we want to bring forward to highlight this issue. I do also want to share something very unique about this conference. In our keynote speaker, Bonnie Lynn Sweenor, discussed dismantling the roadblocks for health equity for people with disabilities. And this morning, we also had two sessions, one on the power and impact of storytelling and data with doctors with disabilities, and the other on healthcare experiences for LGBTQ plus disabled people. And this afternoon, for our third session on inclusive cultures, we had John Kemp, who really dove into practical strategies to foster inclusion, work he has done for many years, including supportive practices and inclusive policies to create an atmosphere in which disabled people can not only actively participate, but also become leaders. These issues of autonomy, self-determination, and cultural transformation are important. We also talked about power, the power of mentorship, as well as AI and accessibility to disability healthcare, as was just mentioned, about using that in order to navigate these spaces in the healthcare system. So first, to start off, I am really interested in hearing your thoughts based on my own experiences as a deaf professor focusing on health inequities. As Dr. Sweenar in our keynote spoke powerfully to about the need for transformation in our healthcare system. And I'm interested in the panelists' response, taking a few minutes each to think about what needs to be transformed in our system, what that transformation might look like, or what it might entail, or in other words, maybe a better way of stating it would be what should be our action manifesto, our call to action. What could that possibly look like?
Well, that's loaded. Um, I'll start. So I've been around the medical center for 36 years doing various things. And institutional change is so massive and so difficult, that I can only think of baby steps to lead to, like, we've had Lisa actually come and do grand rounds in our department because I had faculty come to me asking about how do we help the, we're the clerkship coordinators and directors, and how do we understand accommodations, and how do we begin to help our medical students and other trainees to get what they need, to give them their best learning experience, because we want them to be successful. So I was thrilled at just a conversation with some of them. It's like, oh my gosh, I have the right person to come. And because I coordinate grand rounds among other educational DEI things. And also from there, we had a roundtable. We have DEI roundtables quarterly. And so I had, again, other faculty asking me, what can we do? It's, for Disability Month roundtable. And so we actually had Suchi and Amy, who was Boguadias, who was with us earlier as well, and two others come and share their experiences and what we could do to help them understand them and not stigmatize them. So those are some small steps that we took to lead to what we hope will be a bigger change and transformation.
I guess building off of what was just said, and thank you so much, OBGYN has been by far the most amazing opportunity to give grand rounds because you can talk about the patient and the provider disparities in a really meaningful way. But I think that, going back to what Bonnie Lynn was saying this morning, I think until we're committed to gathering disability data across all of our surveys as a demographic that is important and valued, I think we will continue to struggle to fully realize everything that's happening in our spaces, whether it's employment or education, whether it's with our patients. I think that this has to become part of the norm. And I know that Dr. Sweener is working really hard on all of our behalves to make this a realization as well. Having that designation with the NIH was tremendous. So many of us are doing this work, but we're in situations where the work isn't getting the value that it needed. And by value, I mean getting the funding that it needs. It's really difficult to get funding in this space. And that designation allows many of us to also put this work forward as important health disparity work. And so that can be funded. And so that's a huge part of this. I think leaning in to what Dachin is saying about the baby steps is also equally important. So many people are very, very frustrated, and rightfully so. I get a little incensed myself when I'm asked to write a paper or a commentary reciting the same things that Lisa Iazzoni, Christy Kirschner, right, Bonnie Sweener, all of these people have said countless times, and it's the same ask for the same conversation. And I think, why are we having the same conversation 10 years later? And so I know that it's frustrating, but those baby steps and continuing to move forward are really important. I have found for my work, and I'll just speak to my work, I think we have been I'm very grateful for this. I think we have been very influential in the medical education space. And I attribute that to our very positive approach to advocacy and to taking the small wins repeatedly. Because when you have these small movements and these small gains, they stick versus backsliding if an administrator or someone in a position of power or leadership decides that this isn't important to them or it's not part of their initiative. And so even though these are small little baby steps, every time a paper comes out, every time a leader is willing to say something, I count those wins, and I keep those wins in a very sacred place, right? Put them in a folder on your Outlook, or make a list and keep it on your desk, because there are days where it feels like we're not winning. And it's important to go back and ground yourself in the facts that we have come a very long way. And then to continue to push the agenda when it feels like you're in a good, safe space. Events like this are certainly, certainly helpful for having these critical conversations.
That is a key point right there. Capitalism and the very small wins that we can make. Did you want to add anything, Cameron, to what was previously stated?
So I would agree with all those things. I think, from a sociologist perspective and doing stuff on how do people think, how do they act, how do they make decisions, which is what I spend a lot of time doing. I spend a lot of time talking about empathy and how right now we're in a crisis of empathy where people don't have empathy and they don't care in certain ways. And so how do we get people to act? We get them to first have empathy. And I don't mean sympathy, I mean empathy. And that starts with value, which is something that Lisa talked about, right? There has to be value placed on the view that people with disabilities have value, that we are valuable to organizations, what we say is valuable, all those components. And until we kind of get to that place, we can't generate the empathy and we can't generate the action. So that's kind of how I think about it from my lens.
So now let's take the opportunity to think about other things that might have come up today that you might have found particularly instructive, interesting, or important to highlight. Oh, what did you learn essentially from other panels that we participated in?
If I can be so bold as you can see, I'm really enthusiastic for this question. I just am in constant awe of the mentorship program, the mutual mentorship program, the flattened hierarchy, the sense of community. I think that what has been done in that space, what they have created, is critically impactful, and perhaps one of the most impactful things that's been done in the last decade, because they created this community, this safety, this environment where people could connect with other people without having to be publicly out about their disabilities. I think you can go to this space and you can be at any level of disclosure that is comfortable for you, and still find a community and still find people to lean into, potential mentors. And you get mentoring. You don't necessarily have to connect with an individual. You're getting kind of a sense of mentorship through the conversations and through hearing other people's stories. So I am deeply grateful for the leaders of that group, and just knowing what they've created. We send so many people there, and I think it's one of the most impactful things that has been created over the last decade.
Any other thoughts that might come to mind? What about if there might be anything that was not sufficiently attended to today that we might want to discuss now and have a chance to engage in? Is there anything you want to add that you think would be essential or important to add to the conversations we've had during the course of this conference?
I wanted to, I actually didn't do my description, and I haven't been in any sessions earlier. So this is Dakeen, and I am very light-skinned, Scottish light-skinned with silver hair. And I have on a black shirt with colorful embroidered flowers, and my background is a teal blue painting, plants, and books in my living room. So I was so struck by the theme of storytelling through the day, because and how important it is, what a difference it makes. And unfortunately, as time goes along in people's trainings and profession, that there's less and less time to hear the stories. And probably the best clinicians, best teacher, are people who use best evidence that comes from the data. But as Dr. Was it Visser earlier, maybe that was her name, said, the data without the stories are nothing, and that we absolutely have to have the stories to, I don't know, well, Cam, you were talking about empathy, and the stories are what bring that and make for the really true empathetic, caring care and treatment strategies, and also the care of our learners, for sure, and of our colleagues who are living with these stories of disability, chronic illness, and are fearful about disclosing. But it seems that once we can hear the stories and the narratives, you can hear it from your patients, but you also have to hear it from the people around you and the people that you are working with and mentoring. And it's so powerful. It really has struck me all day. And I thank everybody for it.
Thank you so much for bringing up the issue of storytelling and stories and how important they are in many ways, both for policy and in terms of practices. So I'd like to take the opportunity to ask each of you about your own stories. I'm wondering if there was a pivotal moment perhaps in your own journeys in terms of kind of coming out of the closet, so to speak. If you have internal ableism perhaps, or any storytelling that you wanted to share that you've seen out there. What I'm thinking almost about internal ableism specifically within our own stories. Were there any key points that you might want to share? The floor is open to you.
I would say that I started this work as a non-disabled person. And when I got my diagnosis at the age of 41, I struggled. I would not have identified, I'm now 54. So if we're talking about timeline, I think for me going through that diagnostic process was really solidified my commitment to doing the work, because I was able to have experienced the ableism and the mistreatment and the lack of empathy, Dr. Whitley, that you talk about in our healthcare system. At times, I felt isolated and alone. It was a pretty bad feeling. And even though I had been given a diagnosis, I felt, speaking about internalized ableism, I felt like I wasn't disabled enough. And there were times that I was functioning without barriers. And so it was really a decade-long struggle to lean into that. And a very interesting kind of poignant thing for me was having a learner that shared my category of disability come to UCSF. And at that time, I had just received my diagnosis, like within a week of seeing the student. So I was doing the intake with the student, and I was saying things to the learner about empowering her to own her disability, to ask for what she needed, to feel safe in that training space. And at the same time, I was holding a new diagnosis, and I didn't feel safe, and I didn't feel empowered, and I didn't feel like I could ask for anything. This particular learner, we've stayed connected throughout her training, and she's now a fellow, and she will be an attending very soon. She will be a rheumatologist. I have a degenerative autoimmune disease. And I've waited a very long time for her to become my physician, because she will carry that empathy. She knows she understands both the clinical impairment, the emotional journey, the psychological impact. She gets it. And I've waited, I cannot wait for her to become my treating physician. And it has been a very long journey. And I know Pete knows this. I have struggled to engage with rheumatologists because of the overwhelmingly ableist and just flat out not nice treatment of people who are going through this process. So I think for me, I've not only experienced this internalized ableism of saying, you know, I'm not disabled enough, I can't ask for anything, but I've also experienced the feelings of shame and feelings of being scared in my own institution to disclose and to ask for anything that I need. Only recently did I begin to actually ask for things that I need and take the time that I need to do things. I kept saying, like so many of us do, when I get promoted, I'll ask. When I get my next grant, I'll ask. It's like all these safety mechanisms that you want in place. And I think it's still a struggle for many of us, even when you're producing, even when you're bringing in funding, it is really difficult.
I think many people in the audience would second that and would relate to what you just said.
I can speak a little bit to that. So oh my gosh, I agree with so much that Lisa has said. And, you know, on my journey, I didn't really, I was not okay with being labeled disabled or with a disability or having any of that until I received tenure, really because of my experiences. And it really wasn't, I feel like I've kind of lived two lives. Like I do this advocacy, but I don't actually out myself. And then I am in my academic world and I do environmental and animal and related work. And so it's just like two distinct things. And it really, honestly, wasn't until Ken approached me and Pete approached me and said, "Hey, would you talk about this?" And I was like, whoa, wait a second. I do, but I don't, right? I don't in these more public spaces. Um, and then that has really opened up a lot of things around this. So, you know, for me, there was a lot of shame, a lot of fear from my previous experience. And then the other thing I have to be realistic about is I'm a transplant patient, and there's a lot of stuff around compliance. And I know that, right? I now I publish with teams who are doing transplant medicine. And so I often worry about being too much on those records, right? Here, I'm already a trans person. I have Kawasaki's, neurodivergent, like I have all these things. And so I'm often thinking about when I need care or when I need other things, how is that going to look in the future if I need another transplant? How am I going to be evaluated? And that's really complicated too. So that's why I'd say there's this other kind of piece in that. But then the last part of that I'll say is, as a trans person within the LGBTQ community, I feel like there's a lot of support for being open about disabilities, and I feel very supported in those spaces. But when I walk outside of those spaces, I don't necessarily feel supported, and so I'm not always vocal about all the things.
Thank you so much for sharing that. It's very powerful. And that brings me to my next thought. Disabled people and their allies are always fighting to even be seen as a group that is requiring supports, so to speak. So it's a category of people who might face health disparities or to be viewed that way. So I think a big picture, take-home story from today. Does anyone on this panel have a message to the people in power? If you had perhaps a magic wand that you could actually change something that you would like to see, what would that look like?
I think it's no secret. I say it whenever I have the chance, but I am hoping I will retire in 10 years, maybe a little bit early, we'll see. It is my hope that by the time I retire, that there will be standardization of accommodation and procedures, the process for getting accommodation in every single medical school across the country, and that will be reinforced by an agency with some teeth, perhaps the LCME.
That would be a great dream. That is a great dream. And I certainly hope that it is possible. I'm hoping that the people in the audience, the people who are running this event, and all like-minded people out there will join forces in that effort. So, Cameron or Dakeen, did you want to comment or jump in?
Well, being in the medical school, yes, agree with Lisa. And that there's not this fighting for everything. And I don't have a disability, but I have a family member that I am spent 4 decades caretaking. And that's when I learned to fight, like bring to every single doctor's appointment, and I hate that. We all do. We all hate. And then my husband had a very debilitating illness, and I felt like I was always going in and fighting, and you have to have an advocate, and to add where I just hope that we can put our chest down, our fists down, and walk in and to be able to talk about whether you're a learner, a patient, profession, all of the above, which you are, Cam and Lisa, that the stories can be heard, that you are the best advocate, but that you don't have to keep advocating, and that you have, and what I would like to see every single physician become is a doctor, that a primary care doctor, this person in my family, who became her case manager, essentially. We've had a couple doctors like that, and people who've cried with her, even physicians, so that empathy makes it so that they want to do everything that they can pull together and go the extra mile to help someone who can't always be in the fighting mode.
Yeah.
To kind of extend that, in the social sciences, I know the issues that graduate students face, right? They face those. But to see what is occurring among medical students, and it really comes to light that it's higher education, that in general, there's a problem with how we are taking care of people and how we are seeing people and how we are advocating and creating resources and access for people. And so, I think the one thing that I took from this is it's across the board that this issue is happening, right? And to figure out ways that how do we support all students in higher education. I mean, that's where I'm speaking from as a professor, right? Like now I'm thinking about, wow, this is a really kind of a prevailing issue across the board that needs to be addressed.
Yeah, so we've just talked about some of our dreams, what we would hope for, the problems that we've seen. But now, as we wrap up this conference, let's think about what the next steps might be right now after this afternoon. What could be our action steps? What would you like people in the audience to think about? What would you like them to do? What steps could we take to make the change that we want to see?
I would encourage all of the learners on the call today, or any medical school faculty member, or as you heard when we did our talk, we've just started Access in Nursing. So nursing schools, we have a plan to start Access in Pharmacy in 2025. We're doing some work with physical therapy right now. We have somebody who's really excited to take a leadership role in this space. I think taking the AAMC report from 2018, and even though it feels like that's a long time ago, I'm always surprised at how many people have never read it. It's really comprehensive. It still holds today. And to give it to an administrator and to say, let's start a conversation. What can we do? And then to join the mentorship program, or MSDCI. There's a pretty strong underground of medical students talking to one another and comparing notes, to be honest, about what's happening at medical school A and what's happening at medical school B. And, there's a pretty good network of disability resource professionals as well, sharing what they're doing in these promising and progressive practices. And so I really think it's that connection that reduces the barrier that is driven by fear. So we can't do this, we've never heard of this, but oh, here are 5 schools doing it. Let's talk to them. And the minute someone else has, whether it's implemented an accommodation successfully or had a successful experience, it reduces that kind of forward motion fear of, well, we can't do this because it hasn't been done. So it's really just, I think, breaking the cycle of fear that's happening, and the lack of communication that's happening between medical schools, which I'd like to have happen in a more formal way, right? To have a system that's solidified. But until we go to that place, that magical Wizard of Oz place, I think that having DRPs have these conversations and having students have these conversations starts to connect the dots of what is possible in medical training and other health professions training.
That's great. That's a beautiful long-term to-do list right there. Any other thoughts from the other panelists? Any action steps we could take?
I would encourage anyone and everyone, and thank you, Lisa, for the great words about DM3P, to join it and become part of the community. And also, I think in your institutions, for those of you who have any kind of say or can suggest, like education, like grand rounds, DEI roundtables, reach out to those in your department. I think it was Pete who said earlier, go to the the DEI, diversity, equity, inclusion committee in your department or in the School of Medicine, and begin to take steps to bring disability into that space. And if anybody wants to reach out to me, I'm really happy to talk to you about doing these great roundtables in your department. They're like an hour, they're informal, and also about finding grand round speakers for your department, because DEI, now there's backlash against it, as we're starting to see, but DEI is a place where there's a lot of grand rounds happening in many departments, in many medical institutions. But let's bring disability into that space. So reach out. I'd be really happy to talk to you.
Yeah, just to kind of piggyback on that. So I've done a number of these roundtable type things in different medical schools, or been brought in to talk about my different identities and disabilities and stuff in that way. And it's been really fun and really affirmative as like a patient advocate, researcher, all those components. And so I'd encourage more of that, where we can really sit down and have dialogue with students. And I would encourage people to share their stories if they feel comfortable and have the space that they can share their stories. I know not all of us can share our stories, or for a variety of reasons. So, I think, but those of us who can, I think it can be really powerful to be able to do that. From an institutional perspective, we should not always have to share our stories, right? And in doing that, the institution, I think we need to figure out ways that institutions provide support for us to share our stories. That we can't always just be volunteers to come in and spend our time and our energy and to have our expertise utilized and capitalized on without anything directly in return. And so there needs to be more conversation about the value of our stories and the value of us in these spaces, so that we get, adequately compensated, and compensation shows value, right? So once money is put into this, that solidifies some of that value component. And so I think we need to have more conversations about how do we show value with the economics and what we're doing in our departments. Situations. Yeah.
Yeah, I think so many of us are hoping that these storytellings, and the power of that is not just of the stories themselves, but also the ways in which they will impact policies, practices, and procedures. Yeah. So with that, I realized that, I read a recent article in the Lancet on structural ableism in medicine, and it was discussing 6 different steps to break down ableism in healthcare in medicine. So do any of you have any thoughts about dismantling ableism in medicine? And then we will wrap up, and I will turn it on over to the next person. Okay.
I think the biggest feeling I have about it is more of a reminder. And I think we tend to think of structural barriers as these all-consuming, overwhelming, indestructible structures that where do we even begin? But the reality is that these structures were created by people, right? They were created by us. So when we talk about structural barriers, we're talking about policies, procedures, physical space. All of these things were created by a group of people who sat around a table and made a decision about what was going to happen. Because of that, I feel very confident that if we get the right people at a similar table, we can deconstruct them, and that it is not as difficult as we think. And we need to challenge the leaders who say, oh, it takes time and it's this and it's that, to say, well, we built it. We can tear it down and start from scratch. So just really empowering people to think about this as a worthy goal and not this overwhelming kind of abstract goal that's somewhere in the future. But now we can take one policy, just start one policy and critically evaluate it.
Well, thank you all so very much for your time in advancing disability equity. I would not be here today with the ADA and the policies and practices that we continue to build to create the big changes we want to see. So now I'll be turning the tables back over to Peter Polis, Clinical Associate Professor of Radiology, who leads the Stanford Medical Alliance for Disability, Inclusion, and Equity, for closing remarks. Thank you for joining us today.
Thanks so much, everybody. Great wrap-up session. I appreciate you. Don't worry, don't leave, everyone. This is where on our YouTube stats, we watch our audience dropping like a rock from the sky. But please, if you have a moment left in your day, if you have any stamina left in you, just stick around for my final remarks here. So, first of all, a big thanks to our funders. These 3 entities give us the majority of our money. My department, radiology, the School of Medicine, Office of Faculty Development and Diversity, and the Stanford Medicine, or Stanford, the Adult Hospital, Stanford Healthcare Office of IDHE who I think is changing their name to DEI, but this is what they were known as relatively recently. So these are our main funders here. And then, oops, got a little lag here. Wow, that went really far in advance. Having like, oh Lord, something's going on. All right. I won't press the button more than once. Okay. These are our sponsors. These, and I'm going to call them out by name. So psychiatry and behavioral sciences, neurosurgery, Department of Internal Medicine, the Well MD and Well PhD program, anesthesia, perioperative and pain medicine, radiation oncology, the Maternal and Child Health Research Institute, the Human Resources Group at the School of Medicine, and Chemical and Systems Biology. And my friend Izzy made this word cloud about today's conference. And I think that, you know, these words have such power. These are some of the themes that we talked about today. One of the feelings that I have right now is pride. Pride in my team, proud to be a part of this community. So proud of what Dr. Whitley said about me and Ken, that just by inviting him to share his story in this space, we sort of helped him on his own personal journey toward disability acceptance, that disability rights are human rights, that we need to eliminate the stigma. There is nothing wrong with being disabled. Disabled people are not a liability in medicine. We are not a problem to be solved. We are a solution to be sought after. We are doing the hard work to make medicine an equal opportunity space for everyone, not just those with disabilities, and improve patient care for everyone. The word care, we care about each other. We care for our patients. We take care of one another. Not ashamed to admit that I am living an interdependent life. I have paid caregivers, I have volunteer caregivers, I have family caregivers. If not for the people taking care of me, I would cease to exist. This conference and founding SMATI has really helped me along my own personal journey, from somebody who used to say that I was injured or hurt, or you know, I had a spinal cord injury, to being able to say I have a disability and to call myself a disabled person with pride, and tapping into the power of that word and the power of that community. And, you know, I used to be ashamed of sitting in my wheelchair. I was so excited to get a Segway so that I could ride around standing up and nobody could tell that I was disabled anymore. And I recently, my Segway broke down and I had to use a wheelchair, a motorized wheelchair. And this is the first time I really used a power chair in public. And I mean, I don't even know how long, 10 years or more. And it was such a different feeling. I was like proud. I was zipping around and smiling and participating. And I felt just nothing but pride to be a disabled physician cruising around the medical center, taking care of patients and teaching students and residents. So it's just such a different feeling inside since starting SMATI and since joining this incredibly inclusive community. I hate asking for money, but there's a donation button on our website. If you didn't pay anything for the conference and you think that you should, or you feel like you can afford to make a donation, please feel free. I want to thank our main event planner, our event planner in chief, Katie Ponches, who's been planning this event for now. This is her 5th one. And without her strong organizational skills and exacting attention to detail, exacting in the best way, this conference could not possibly come to life. So thank you so much, Katie. These are some of our other assistants, Devora Kanther-Katari, who's in charge of communications and in charge of like many of the behind the scenes logistics also. Thank you so much, Devora. I'll see you later on. Hopefully you're on your way over to my house right now for a cocktail. Amy Thomas, who does our web and graphic design. Denise, who sets up endless meetings for us, and Sheila Sanchez from the Diversity and Access Office, who arranged our sign language and closed captioning. And while we're on this, I should also say thank you very much to our sign language interpreters and our closed captioners for making this event accessible to our deaf and hard of hearing participants, speakers, and moderators. We have a warm spot in our heart for you and the access you provide and the beautiful language we get to watch you speak. This is our technology and social media team. Louis Tan is the maestro behind this entire event. He taught himself how to do this from scratch 4 years ago, and now can go out into business for himself and make like an excellent living if he had to, doing conference technology. His assistants are Eric Lee and Nicole Turk, and Maya Matheny is our social media lead and future medical student this year. This is our planning committee, me, Devora, Katie, Lori Leventhal, Belfer, Jen Lin, Ken, Louis, Dakeen, Amanda, Jody, and Mandy Myers. This is our board of directors of SMATI, including Miranda Stratton, Amanda Taus, Joe Garner, Eric Sibley, Preetha Vasavia, Zoe Martin Lockhart, Carly Cood, Louis Tan, Argavan Salas, Doug Noy, Lori Leventhal Belfer, Jody Greenhall, Lynn Jen, Michelle Bizo, Shayla Katadia, and Suchita Rastogi. This is me and Ken with our Stanford Puffies. Ken, I love you. I'm so sad that you missed that comment by Cam, but you'll be able to watch it in the recording. We have another conference coming up. Believe it or not, I can scarcely believe it myself. On May 18th, we have a full day devoted exclusively to disability and telehealth, and registration for that is now open. You can register on the SMATI website under events. We have an amazing lineup of people from experts from many disability communities, from the top institutions in the country. We have corporate participants from Apple and Zoom, the American Telehealth Association, the National Council on Disability will be there, the AAMC will be there. It's going to be a massive event and a great learning opportunity. This is a plug for the Disability and Medicine Mutual Mentorship Program. Again, if you want to join us, and I ask that you do and refer people to us, our email is info@disabilitymedmentors.org, or you can find us on the web at disabilitymedmentors.org. We paid a lot of money to get this conference certified for CME. So here is CME information about this, which I'm sure none of you can even read if you're on a small screen, but it's also on the website, and we will be emailing the participants after the course with the course evaluation and claim CE evaluation. All right, I'm going to stop the slideshow here. And stop my share. All right. Well, that brings us to the end of the day. It was a pleasure having you all here. I hope you're all as energized and exhausted as I am. Please connect with us, connect with the Docs with Disabilities Initiative and the mentorship program. We're talking about action steps at the end of the day, and I really think that sharing our stories and being out there as much as we can be, or as much as an individual can be safely out there, will change hearts and minds about disability throughout the country. If you're not safe in where you are, perhaps you can find one ally, a friend that you can talk to about your disability. And if you can't do that, even please just join our mentorship program. And so thank you all very much. With that, I will say good afternoon. I offer you a toast to good health and good cheer. Thank you. Good night.